recorded.
The live started, sir.
Yeah. Good evening, dear friends. Welcome to another webinar from MedEdTrust. This time, what we are trying to do is we are trying to give you a little bit of advances in coronary intervention 2020. And as usual, MedEdTrust looks at shaping the future of medical education. And this time, in our webinar, which is a two-part series, one today and another tomorrow, both between 7 and 8:30. We have a good galaxy of interventional cardiologists and chaired by two very eminent people, Dr. Manohar and Dr. Srinath. And what we shall do over the next, let's say, about 1.5 hours or so, with short presentations and a fair discussion among all the panelists. And as usual, MedEdTrust is going to give you another episode of an educational series. And we have Dr. Pari, Dr. Ishwaran, Dr. Srinivasan, Dr. Sundar, Rajendran, and Rahul presenting today. And I'm the host today. And the two chairpersons for the day are Dr. Manohar, Senior Interventional Cardiologist and Consultant, Venkateshwara Hospital, Fortis Mallar, and he's a professor at Stanley Medical College. And the other person is Dr. Srinath, well known to all of us, who is DNB Cardiology at Apollo Hospitals, very good friend of mine. His field of interest in everything in cardiology. I can't pinpoint everything because he has so much of interest. I think he's got an interest in everything in cardiology. With these few words, I'll hand over the session to Dr. Srinath to take over the proceedings and introduce the first speaker. Dr. Srinath, all yours.
Thank you, sir. Thank you for the introduction. Good evening, friends. So let us start the session because I think we are already 5 minutes into the session. So we will be starting with a presentation by Dr. Arun Pari. The presentation is titled When Buddy Becomes an Enemy. So can you, Dr. Arun Pari, he is a consultant interventional cardiologist at Bharat Hospital in Chennai, Nanganallur. So he did his MBBS undergraduation from Ramchandra, post-graduation from Madras Medical College, and he did his super specialty from Madras Medical Mission. And, he's been a consultant cardiologist in Madras Medical Mission, and he's done his FNB from Narayana Hrudayalaya. Over to you, Dr. Arun Pari. You can start your session.
I'll stop sharing. Dr. Arun, you can start sharing now.
Sir, yeah.
Dr. Arun Pari, you're there?
Dr. Arun?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Yes, Dr. Arun.
Start
Good
sharing.
evening.
You
Good
can
evening.
start sharing.
Good evening.
You can start. We're able to see your screen, Dr. Arun.
Yes, sir. Just.
You have not opened the presentation.
Yeah, I've not opened it.
You open the presentation and then start sharing. Why did you close your presentation? Start. You want some time? Organize it?
2 seconds.
Yeah.
5 seconds.
Dr. Srinivasan, I think mute yourself.
Sir, you can click the share screen and click entire screen. Click
Yes.
share. What is that you are seeing, sir, after clicking the share screen?
Hello. One second.
So once you click the share screen, you can see click here to share this screen. Click on that, sir.
Nearby the disconnection tab, you're able to see the TV
There is.
like that TV box.
Arun,
First
can
open
you
the
see
PPT.
that red end call link?
No.
One.
Yes.
Yes.
Now it's fine.
Now we are
Just
in.
fine. Go ahead.
Yes.
Yeah. Put on the PPT slideshow mode.
Click on the slide.
You're able to see, sir?
Yes,
Good.
yes, Dr. Arun.
Yes.
Yeah.
This. Good evening, everybody. Today we'll just see an interesting case wherein. Good evening, everybody. I'll just share an interesting case wherein.
I request others to mute their. Kindly mute your devices, please. Except Dr. Arun. Thank you.
Yes.
Please, Dr. Arun, you can go ahead.
Good evening, everybody. Today I'll just discuss an interesting case wherein PTCA hardware used to facilitate a procedure ends up in a problem. So the history is a 79-year-old gentleman who's a diabetic and hypertensive. He was admitted with infravol MI and RVMI with 5 hours time window. As the patient was elderly, attendants were reluctant to undergo a primary PCI. So we had initially lysed him with tenecteplase. And 8 hours post lysis, patient developed chest pain with ST elevation. So he was patient attendants were counseled, and then he was taken up for a angiogram and rescue angioplasty. So this was the angiogram which showed dominant right system, but it was a severe triple vessel disease. The left main was normal, but the other LAD and LCX had critical lesions. And they were all also calcified. So this was the right coronary system, a dominant right coronary system with tortuous RCA and severely calcified in the proximal segment, with tight stenosis in the proximal, mid, as well as in the distal, with the TIMI2 low in the distal RCA and the PLV and PDA. So initially, I took the radial axis, but then later decided to switch over to femoral as the vessel was very tortuous and calcified. A routine workhorse wire wouldn't cross like the BMW as well as the run through. So I took a whisper wire and with great difficulty managed to cross with balloon support. So pre-dilatation was done with two balloon initially. Then subsequently we would get a lumen in the proximal RCA. But to advance bigger diameter balloon, I had to take in another. I had to put a buddy wire. That I used a BMW wire since it was already available, which I tried initially to cross the lesion. So I used a BMW wire and positioned it in the PDA. And subsequently, I took a 275 balloon non-compliant and post-dilated the proximal RCA and also the mid segment. So after post-dilatation, I proceeded to stenting with 3 into 38 millimeter stent. It was difficult to negotiate the stent to the calcified portion, but with great difficulty after deep throating the guide, managed to deploy the stent. I wanted to deploy it actually in the distal and the mid RCA, but it wouldn't cross beyond that. So I deployed it. At least I thought I'll just fix the proximal lesion initially. So I deployed it in the mid and proximal portion. The patient was very restless and was hypotensive, and I wanted to do it quickly. So in that hurry, I deployed the stent, but I deployed the stent only at nominal pressures. But then I thought I should go a little high pressure, and I tried to pull the wire, the BMW wire. When I tried to pull it out, I ended up seeing only the shaft of the wire, but the floppy tip was caught inside the stent struts, and at least 3 millimeter of the 2 to 3 millimeter was of the wire was in the distal portion, was outside the distal portion of the stent. So the slide clearly shows that that wire is at the distal portion of the stent and hanging freely. And I was just waiting for a few minutes. I tried to pass a small 1 millimeter balloon through the stent and tried to remove it, but couldn't. Meanwhile, thrombus started developing in the proximal as well as the mid distal portion of this wire, that BMW wire floppy tip. Then after giving an additional dose of heparin and 2B3 inhibitor bolus dose intracoronary, I decided that I should not attempt to remove it, rather than jail the distal end of the floppy tip wire. So then I took a non-compliant balloon 3.25 into 15 and post-dilated the stented segment of the mid and the proximal RCA well to facilitate easy delivery of another stent distally. So the mid RCA was again post-dilated. Then I took another 3 into 28 millimeter DES and deployed it in the distal RCA, making sure that the distal free tip of the wire is jailed. Then deployment. Then deployment in the distal RCA. So this is the shot after the stent deployment. Then I again post-dilated with a 3.5 non-compliant balloon. The entire stented segment I post. So this was the final result. So I had removed the wire, and this is the jailed wire. I mean fractured tip of the jailed wire. I could achieve a good result finally with good flow in the distal RCA as well as the branches. So the just a brief so the incidence of fracture and the jailed wire is about 0.2 to 0.8%. in all the interventional procedures. So the usual site of break of the wire is at the junction of the flexible 3 millimeter tip and the shaft, which is the weakest point. The usual causes of the fracture of wire are the excessive rotation, forceful traction of the wire, and of course repeated use and use of bulky devices like Rotan aspiration catheter. And of course, with respect to the vessel anatomy, very calcific and tortuous vessels are prone, the wires are prone to fracture. So once we have noticed that any fracture of the wire has been identified, we have to make sure that the first important thing is we have to make sure that the ACT is adequate and the access position should be changed from from femoral to radial to facilitate use of snares and other catheter and other devices to enable removal. And usually if the fractured segment is at the proximal edge of the stent or in the osteoproximal area, it is amenable to retrieval. But if it is in the distal portion of the vessel, then it is usually easier to jail the wire rather than to attempt removal. So we could use a percutaneous management of the fractured wire. We could use a balloon, a small balloon like 1.25 to create a space between the stent and the vessel wall and attempt to remove the fractured wire using a snare. Double or triple wire technique is the technique where 2 to 3 PTCA wires are passed into the vessel and entangled so that the jail wire gets trapped in the other wires, and which facilitates en masse removal. And use of a guide catheter or a micro catheter can also be done, so that the guide catheter is deeply wedged into the proximal portion of the vessel, and another balloon is inflated half in the vessel and half in the guiding to enable and can be removed en masse. And retrieval also can be done by snare or bioptome, which can be attempted in larger caliber vessels. But stenting and jailing the wire is the most feasible, and it involves the least manipulation procedure, which will help us to get out of the issue. Thank you, sir, for your time.
Recording is on.
Dr. Arun, it was really scary actually, but then you escaped with a good result.
Yes.
But just wanted to know from the panelists and other experts in the group.
Stop sharing, Arun.
You can stop sharing the screen.
Yes, sir.
Yeah. Did you even consider using a snare, or was it not available, or?
Actually, it was at 8:30 in the night, 8 to 9:30, and snare was not available. I couldn't call anyone also.
Okay, sir. Yeah.
I didn't consider, sir, actually.
But it will be difficult in a stented segment, as you rightly said. The distal portion is very, very difficult to snare it and bring it out.
Yes,
But what you did was probably the right decision at that moment. So
Yes,
long-term results of these jailed wires, we really don't know, sir, exactly. So Prabhakar, sir, do you have any inputs on that?
Actually, what happened was I had a similar experience, and I was looking around, and the problem is not what you did. The problem is the wire you selected. When you use a BMW wire, the hydrophilic wire, it doesn't come out. When you try to jail this wire, BMW is notoriously prone for this. So if you are going to jail it or put it in a side branch and then try to do anything, generally use a cyan glue.
Okay.
Cyan
But-
glue will not have, this will not happen. I had an experience once. I broke one tip of the wire. I same with BMW. I learned it by experience. Maybe next time I'll try to project that case. But you are bold enough to project it. But the reason is I think all of us should learn that if you put a BMW wire or a wire like this and keep it in the side branch and close it, when you pull it out, this is what happens. It'll get snapped. It doesn't happen in the 7 blue. 7 blue is supposed to be a better wire when you start doing it, when you jail it. So when
Actually,
you jail it, your choice of wire is very important.
actually,
And once you got into trouble, I think what you did is fair enough. If you can't do anything, just jail it. In fact, mine, I left a 2 millimeter or a 3 millimeter trip there inside. We put a stent, deployed it, and kept it fine and left it alone. Now it's close to 1.5 years since this happened. Patient is still doing fine. He came for a follow-up 1 month back.
yeah, patient was on follow-up 2 years after the procedure. He was reasonably mature. And the reason why I took the BMW is I had already opened a new wire.
Opened it.
That's a mistake we
Cost
make.
concern.
That's a
Yes.
mistake. So next time, don't ever do it. You know what happened? After
And I
this,
should have-
actually, after this, I changed my workhorse wire from BMW to 7 blue.
I should have removed the wire before deploying the stent.
Exactly. That should have been done actually. Before stenting, before deploying the stent, you should have removed the wire. That's
The other thing that
probably
people
in
do
that.
is you keep the stent and
Okay.
go for a lower pressure.
Yes,
Make sure that it is staying in place. Just about 3-4 atmospheres. Remove the body wire.
yes, that's
Small
what-
pressure, remove the body wire because then it is not going to get stuck. Because if you
Like-
go for a higher pressure like 9 or 10, sometimes it gets stuck. Just 3 or 4 pressures, just go there, get the body wire so it doesn't move the position, and then you do it. Sundar, any experience on this?
Yes, sir. Good evening, sir. This is a very, very good and nice case to be projected. And the one doubt I have that is by jailing that wire, actually the stent will have only the studs, that is the open cell. So even though if it is jailing, so there will be a portion of wires will be still exposed to the blood. Even it will be thrombogenic also. I watched two of my two cases in Hyderabad training when I was in training. They used a covered stent to to cover that entire tip. But it was a little deep inside the very bigger vessel. So they used the covered stent to cover it rather than because they were unable to take out. But I watched one case with that. So I don't know whether this jailing of wire with another stent will help in avoiding the thrombogenicity. Also, I wanted to ask Dr. Pari about the anticoagulants. What are the anticoagulants you used for this patient? At least for 1 year or 2 years, you might have used till the endothelium gets developed in the stent.
Yes,
Right, sir?
I used only Ecosprin and Brilliant as a ticagrelor. Nothing.
And I'll tell you what I did in my case. I put him on long-term Rivaroxaban 2.5 twice a day.
Oh.
And nothing happened.
Okay,
He's
sir.
controlled. He's
That's
doing
good.
fine. Like I said, it's more than a year, and he came back and he's doing fine. Absolutely no symptoms, and it was actually I don't remember which was. I think it was into the LA circ. I think it was in the circ. So the whole thing got stuck.
But I had one similar experience. BMW wire, jailed in circ, triple vessel disease, attempted multi-vessel angioplasty, jailed. I did not do anything, center for surgery. That's the only thing because I was not able to yank the wire out.
This
it
gentleman,
broke.
my patient was quite old. That is another option we didn't
Yeah.
put. I think Arun Pari could have probably put that also.
70.
But
Yeah.
generally, covered stent, the problem is long-term results of covered stents are not good.
Yeah, correct.
But leaving a stent open, thrombogenicity is a very important factor. In my case, long-term anticoagulation with 2.5 twice a day has worked. And then I put him on about 3 months of DAPT, and then I put him on aspirin clopidogrel only with this thing. And after that, actually 1 year I continued because patient was maintaining well, checked his hemoglobin on and off. I kept checking on him. He's done well. So I've just continued him on a 2.5 milligram twice a day and I shifted to a single antiplatelet. But I'm not stopping this thing because I don't know what is going to happen. Because if you stop it and he goes through a stent thrombosis, it's over. And it's not going to change his thrombogenicity. Maybe it could have got endothelized, which is very likely, like a bare metal stent.
Yes.
So I thought
One more lighter question will be how to manage the patient attendance about that, sir. I don't know.
half the time it's better to tell the truth, which is what I have realized. Because what happens, he will take the CD, take it to somebody else and take an opinion if there is going to be a problem. And then they will tell you, oh, no, this fellow has done a mistake and all this has happened. So it's definitely bound to happen. I have always found out that telling the truth is the best.
Correct.
But I think Arun got away with it so far, more than 2 years, he says. So I think proof of the pudding is eating it, and he has eaten the pudding well, and he has managed to present it also. And I think learning experience for all of us, I think if you're going to jail a wire, be careful. probably 2 or 3 simple things. Better to avoid jailing the wire when you're stenting it. Remove the wire. As far as possible, remove the wire. And even if you're going to do it, please don't use a BMW because there is notorious in getting caught. Any comment, Manohar?
Sir, one question, sir. How about doing a follow OCT in these patients to see what's exactly happening to the fractured segment?
See, it's a good suggestion, but the trouble is trouble. Patient will ask you a lot of questions. What are you going to do by doing again? So take him in again and try to get into more trouble is more trouble. So everything going is good. I'll leave it alone. But your curiosity is agreed. It's sensible to try and see what happens and whether it's going to endothelize or something. It might be there, but I don't think any data is there. Maybe if somebody finds out, maybe next meeting somebody could come up and tell us if he can find some cases.
I have a patient with 3 months old now, sir. He's doing well as of now. I am planning to do it. I have also counseled them. We will require a restudy to see what exactly has happened to the tip of the wire. Maybe once if it is done.
Arun has opened a Pandora's box. Everybody seems to be having similar cases. I think we'll have one day's meeting only with jailed lawyers getting caught. Right, I think that was a good case. Thanks, Dr. Arun. I think that was a very good case, and I think we should move on to the next presentation if there is nothing else to do. And Srini, you want to present now, or Dr. Ishwaran is ready?
Yes, sir, I am ready, sir.
Yeah, Dr. Manohar, you can introduce Dr. Ishwaran and the case. He's going to present a case of an intervention to postpone the inevitable. Dr. Manohar, sir.
Dr. Ishwaran is consultant interventional cardiologist in Kumaran Medical Center, Coimbatore. He got trained in the transradial interventional course in 2014, conducted by Apex Heart Institute, Ahmedabad. Kindly proceed with the presentation. Dr. Ishwaran, you can proceed.
Sure, sir. Thank you so much, sir.
You can proceed.
Good evening, everyone. I hope my slide is visible, sir.
Very clear, very clear. Go ahead.
Good evening, everyone. My respected seniors and dear friends. I am here to present about an intervention which was done, I believe, to postpone the inevitable. This is regarding a 68-year-old male. I will just move the. This is regarding a 62-year-old male, Mr. Allimuthu, a diabetic since 7 years, sustained acute coronary syndrome, non-ST elevation MI in 2013. The coronary angiogram done at that time showed a single vessel disease with near total occlusion of codominant RCA with a normal left system. He was advised medical management then, and he had a peripheral vascular disease with gangrene of the left toe, and subsequently reamputation of the left little toe was done in 2013. Because his CT peripheral angiogram showed a bilateral SFA occlusion with left external iliac artery 90% stenosis. This is the CT peripheral angiogram. We could clearly see the diffuse disease of the bilateral SFA, and there is a tight lesion of the left external iliac artery as well. In 2017, he had an acute heart failure admission, and subsequently his LV gone down with severe LV dysfunction with multiple heart failure admissions since then. But subsequently, coronary angiogram was not done since that initial coronary angiogram in 2013. Hospitalized at our center in December 2019 with an ACS NSTEMI with acute decompensated heart failure with an acute kidney injury as well. He was stabilized and planned for an angiogram which was done through right radial artery. Could not be done through right radial artery because it was very feeble, and we did a Doppler prior to that as well, which showed a narrowing subsequent to brachial bifurcation. So second coronary angiogram was done using the left radial artery, and it showed a significant tight ostial left main disease with double vessel disease, and he was referred to CTBS for CABG after a viability study, as echo showed severe LV dysfunction as well. In January 2020, he underwent a viability study also, and it clearly showed a significant viable myocardium in all the 3 territories, and with fixed defects in inferior and lateral wall alone. So that old inferior wall RCA territory alone was affected. It showed a fixed defect. Subsequent rest of the area showed viable myocardium. It was planned for CABG, but it was postponed at that time due to financial reasons, 2 hospitalization in 2 different hospitals, and they could not spend much more beyond that. So this is the SPECT imaging. We could clearly see the inferior and lateral wall alone fixed defects, and especially the LAD area was very clearly viable. Worsening heart failure admission in March 2020 again. This course was complicated by acute gastroenteritis, and at this time again rediscussed with cardiovascular team, and high risk LMPCA versus high risk CABG was discussed. But the nature had other plans. His creat went up to 13.3 and he required a few cycles of hemodialysis, and they could do a few cycles of HT and stabilize him, and then he was discharged against medical advice. And at the time again, they didn't go ahead with PTCA as well as CABG in view of corona pandemic, patient related fear factors, all those stuff, and all the reasons were there. And again in May 2020, he had another hospitalization in our center. Again, he came back to us because they didn't undergo CABG at that time. So counseling was done in this admission for an high risk LMPCA after stabilization, and subsequently underwent the same at our center in May 2020. So this is regarding the subsequent LMPCA what we did at our center. So his coronary angiogram, left injections, osteo left main, we could see tight calcific osteo left main disease. Pressure dampening was noted during the coronary angiogram. The proximal LAD had a borderline lesion as well, and proximal LCX had a significant lesion, which is again very clearly seen here. RCA is a codominant vessel and occluded proximally, nothing much to be seen there. So we had a lot of challenges, and subsequent planning was also done meticulously to address this particular situation in our center. RCA is a codominant and occluded vessel, so only surviving vessel is left system, and ostial LMCA is a single point of entry, and if we miss it, it will be the end of the day. And the next challenge was he had recurrent ischemia driven acute heart failure admissions with multiple AK episodes as well, with previous creatinine up to 13.3, which now stabilized to about 1.33. Severe LV dysfunction substrate with baseline low normal pressures, and obviously we can expect the hemodynamic instability during the procedure. Also, he had access issues, bilateral SFA occlusion with left external iliac artery 90% stenosis. So obviously left side femoral option is out. Right radial also we have already documented there is severe narrowing beyond the brachial bifurcation. So left radial was used for coronary angiogram, and now we are planning for a osteo left main intervention. May end up in bifurcation stenting. So we are planning for a femoral access at this time. So only one right femoral access was available, and backup left radial access is alone available. So there is no another contralateral femoral access for IABP backup also. So we did a careful analysis of CAG, and steps are planned meticulously, and every step was pre-planned, and anesthesia backup was also kept ready. Inotropes were added and kept, but was not initiated because of ostial tight lesion, and we are planning to initiate it after left main pre-dilatation. IABP kept as standby, but we do not know where to insert. Access issues were there, and the hemodynamic monitoring was planned with a multipurpose catheter in the LPA through femoral venous access to guide IV fluids and diuretics. Coronary imaging obviously not available at our center, and patient also not affordable as well. And how it was done, that's the next few slides we'll be seeing. We obtained a right femoral vein access, and a multipurpose catheter was placed in LPA, and continuous PA pressure monitoring was done to guide the fluids and diuretic during the procedure. And right femoral arterial access obtained, and 7F long 45 centimeter sheath was placed in situ, and 7F EBU 3.5 guide was chosen for the procedure. So with this stage being set, crossing and plaque modification was done. Wire was placed in the aorta. Since we are attempting an ostial LMCA procedure, we wanted a wire in the aorta to prevent unnecessary guide movement into the LM. Run-through wire was placed in LAD, and a Xeon blue wire was placed in LCX. And pre-dilatation we did using 3x10 non-compliant balloon and went up to 10 atmospheres. So this is the pre-dilatation step. 3 wires there, one in the aortic annulus, and the 2 wires in LAD and LCX. Subsequently, positioning of after a proper adequate pre-dilatation, positioning was for the LM ostial stent into the mid LAD up to the mid LAD. 3x40 stent was chosen for that, and that was deployed. And the stent balloon was pulled back, and proper high pressure inflation was done. And subsequently, left main part was done using a 3.5x8 NC balloon at up to 20 atmospheres. So after this step, we carefully analyzed what happened. The flow was okay, the patient was reasonably stable, and then we recrossed the LCX with the wire, and then LAD post dilatation was properly done with 310 NC at 20 atmospheres. The whole of the LAD and up to LAD ostium, the stent was post dilated with 310 balloon with high pressures up to 20 atmospheres. And this is the shot after the stenting of ostial left main to LAD. Still the ostial left main portion was not completely post dilated. We were evaluating the angiogram at this point of time, and we were discussing about whether to leave it as provisional stenting at this point of time or to go ahead and finish off the planned bifurcation stenting as well. We had some discussion with my colleague cardiologist as well, and the patient reasonably did well until this point of time, and we thought we will do a reasonably near complete revascularization by doing the proximal LCX lesion as well. So we went ahead and touched upon the LCX also. Stent struts were dilated, and subsequently LCX lesion was pre-dilated using a 210 semi-compliant balloon, and subsequently using non-compliant balloons as well. And the LCX stent was placed in tap position. 3.5 into 18 millimeter stent was taken and placed in tap position and deployed at 10 atmospheres. 310 non-compliant balloon was placed across the LAD and across the stent, and then subsequently both the stent balloon and the LAD balloon were pulled and creasing inflation was done. So this is the image of the stent positioning at the ostial circumflex. And subsequently both the balloons were pulled, and we did a first casing at this point of time. Subsequently, LCX post dilatation was completed using 3.5 into 8 non-compliant balloon up to 20 atmospheres. Then kissing inflation was done with 310 non-compliant balloon in LAD and 3.58 non-compliant balloon LCX, and 8 atmospheres in each maximum, and subsequently kissing balloon inflation was done. And left main pot again was done again with 4 into 8 non-compliant balloon up to 18 atmospheres, and ostial flaring was also done using the same balloon. So this is the kissing inflation, and this is the ostial LM pot with 4 into 8 NC at 18 atmospheres, and ostial flaring was also done. So these are the final results in cranial projections. I'm sorry. So these were the final results in caudal projections. So these were the results that we could achieve in this particular patient. This was done in May 2020, now almost like 6 months of follow-up. Patient came at, last week for the follow-up, routine follow-up visit. He is doing well. So patient was very sensitive to ischemia. We had some on-table issues. Each and every step in LM and LAD, pressures went down up to 60s, and PA pressure rose from 25/10 baseline to up to 50/25. And so we had to give time and do the procedure in a staggered manner for the ischemia to settle down, and with inotropic support in the backup as well. Pros and cons of leaving the stent, as I already discussed at the end of provisional LM versus the LCX tap was discussed, and finally we decided that this patient had recurrent heart failure admissions and occluded RCA, so we will do maximum possible revascularization at this point of time. And at 6 months, no further heart failure admissions, reasonably good effort tolerance, is not dependent on others, able to drive a two-wheeler, does his job with improved LV systolic function on echo. The current recent echo showed a EF of about 40% and significantly reduced E by E prime on the echo. So significant diastolic dysfunction reduction is completely lost weight, more than almost 5-6 kgs. All the excess fluids, heart failure fluids were all gone. He is now lean, doing well, happy patient, and ultimately even more happy relatives. And after 6 months, the operator is also more happy. But I feel we have done only a postponement of the inevitable. I am not sure how long he can pull through. As of now, initially I had the thought he may not fairly do well, but until 6 months he is reasonably doing well. Hope he should do well in subsequent years as well. Thank you so much for patient listening, and awaiting subsequent discussion on this.
Sharan, it's an excellent workup. I congratulate you.
Thank you so much, sir.
Any imaging for this patient? No.
No, absolutely no, sir. Our center is a new center, 6 months old center, sir. We don't have not purchased it yet, and patient is also not affordable for multiple devices to be used at a point of time. So we didn't consider it at this point of time.
Okay.
Actually, definitely it would have helped us a lot in choosing our stent size as well as the balloon size, post dilatation balloon size, but we didn't have that advantage, sir.
Okay. Is this patient gone for contrast-induced nephropathy? No.
No, sir. He's absolutely doing well. Creat is now 1.1. In fact, it has come back to normal. Creatinine, urea, everything is fine, sir. All those
But
things
patient,
are the recurrent heart failure related AKA, sir.
okay. But patient has underwent hemodialysis previously.
That was create was 13. That admission of heart failure was complicated with an AGI, significant dehydration, went up to 13. 3 cycles of HD was done. And subsequently, that was in January 2020, so January, February. And by March, he stabilized, sir. May, when we did the procedure, baseline create was 1.33, sir.
Okay. He is on dual antiplatelet or what is the drugs?
He is on dual antiplatelets, sir, both ticagrelor and aspirin, the routine heart failure medication. Now I was able to step down all the heart failure medications, sir. He is completely dry now with minimal diuretic, 10 milligram of ditar alone, and he is on adequate beta blockade. Pressure is fine. He is on AC inhibitor also. I have restarted AC inhibitors as well. He is doing good. He has not risen his creatinine subsequently, sir.
Excellent. Very good. Dr. Prabhakar, please.
Hey, Dr. Ish.
Very well planned and executed, despite all the limitations that you had. I have a couple of questions. Now, one thing is you have a 3 mm stent in the LAD, 3.5 in the CERC, and your post dilated to 4. I thought the LAD should have been a probably bigger stent. Yeah, obviously you didn't have an imaging. Imaging would have definitely given you a much bigger size. And the left main itself, I thought probably would have taken a bigger stent. Probably if you had taken a 3.5 as the main stent, if you had taken a 3.5 as the main stent, you could have gone up to 4.5. I'm sure the left main is going to be much bigger size.
Only thing we had the doubt was like the mid LAD position where we landed the stent that we felt like it was around 3 to 3.25, sir. So we thought we'll go with 3 and upsize even to 3.5 if needed. Maybe for left main, I may be a little the stent may be a little smaller for left main. But since our plan was like we planned like a salvage. We will do osteal LM into the LAD, establish flow. If he is stable, if there are any issues, we'll stop there. Since he did reasonably well and we were able to monitor his pressures as well, VA pressures, fluid, no failure, we took the next step of doing LCX. Actually, we staged the procedure actually, sir. In our mind, we thought we'll drop here if any issues were there. So maybe 3.5 would have been a better option for LM.
What stent were you using?
Sorry, sir?
What stent was used?
Zynes, sir, Zynes. Expedition.
Zynes generally 1 millimeter you can upsize.
Yes, sir, Zynes Expedition.
Probably what I will say, I'll take the suggestion from others. What I will think about is you use a 3.5 mm stent. Don't fully inflate it.
Okay, sir.
Don't overinflate it. Go for a slightly lower pressure inflated. You can always deploy it at that particular level whenever you want. And then what you do, you can pull it out.
Sure.
Because you're going from osteal left main to the end. You can slightly pull it out and then go for 3.5. Landing zone doesn't get inflated so much.
Sure.
And then
Sure.
if you had done a 3.5 there, you have up to 4.5 size, probably the left main would have been bigger. But even in the end also, I felt that left main was a little small compared to that. I think probably, now I like you clearly said, your lack of imaging was probably one of the biggest constraints that you had. Probably when you go for a left main, I think generally I think we should go for a slightly higher size. But ultimately you have done well, 6 months you've shown posting and your renal parameters have stayed put. How much was the contrast that you used?
Around 300 plus, sir. But at the time, we had to, we didn't think of the contrast on table, sir. We didn't think of the contrast on table. We want to pull him out alive. That was a thought at that time.
Yeah, but he got away with it. That was interesting. Good.
Thank you so much.
Is there anything? Sundar, Srinath?
It was an excellent case, man. You are very humble to say that you just managed, but it was very well done, very well meticulously planned. There's no doubt. But the only thing is, will you still choose EBU 3.5 as the guide, or will you go for a JL?
So that question we also had in our minds. We planned actually JL and EBU 3. Myself and my colleague cardiologist, both of us sat down the day before with all figures in our hand, with angiogram in hand. We were thinking all these things. So initially I thought backup should not be a major issue. Only time when we thought backup will be an issue is addressing the LCX. The LCX were more angulated, and any stent which we are planning to take into LCX may be in trouble. Only for that position we thought more backup is needed. Otherwise, for a straight osteal LM or LAD, backup should not be an issue. Even a JL could have solved the issues there. Only for considering that point, if at all we are planning for a complete procedure, we should have a proper backup. So we went ahead with the other reason we had placed an osteal wire also, so as to avoid any injury to the ostium or any unnecessary entry into the ostium. So that was the plan we discussed before the procedure, sir. We considered it, sir, definitely, but that's why we used the long sheet as well for a proper backup. Also, we took a long sheet also. That was another reason also. So EBU with the long sheet will be a more aggressive guide, as you said. Definitely, is an aggressive guide. So we just placed an nostril wire to avoid unnecessary entry into the LMs.
I think the moral, I think very clearly is proper planning. I think you guys did a very good bench
Sure, sir.
planning, and then paperwork you have done adequately, thought about it, and I think well executed. Congrats, good, good. Sundar, anything?
Thank you. Thank you.
Yes, sir. Same as it's a very, very planned and very well executed procedure. And actually, it is a case to be done with the backup of a mechanical circulatory support. But it is Dr. Ishwaran should be congratulated for this meticulous procedure, and he has evaluated very, very well. And I'll go with Dr. Prabhakar that the left main stent was little. I thought I would have taken a 3.5 and go up to 4.5 or something. And but other than that, it is very, very, very well done. It's congrats, Dr. Ish.
Thank you so much, sir. We'll take all of your inputs and apply subsequent cases.
I think I'll invite Srinath to take in the next one. Next one, we'll take Sundar's case. Srinath.
Yes, sir. Dr. Sundar is going to present a case on primary PCI in a COVID patient. Norm of the day, expect the unexpected. Dr. Sundar, as we all know, he is an interventional cardiologist
Yes.
at Kaveri Hospital in Chennai. He doesn't need any introduction. He's very aggressive, and he's interested in imaging and physiology guided PCIs also. Last presentation, I think he was presenting about FFR and all. Over to you, Dr. Sundar.
Yeah. Thank you, Dr. Srinath, for the nice introduction, and very, very. I extend my wishes to Dr. Prabhakar and my teacher, Dr. Manogar. He is my teacher during my DM days, and I always have a very good rapport with Dr. Manogar, sir. So I'll just share my screen and hope you'll be seeing my. Is it okay for you?
Yeah, it's coming in. Yeah, you're good.
Yeah. And so as we are coming to towards the end of the year, as well as hopefully the end of the COVID era, and I'd like to share my experience during this period, whatever we have done the PCI in COVID patients. So a lot of COVID patients came to our hospital and with heart failure, myocardial infarction, and I just selected 2 cases out of those cases to be interesting. And this is a 36-year-old man. He works as an employee in a TV company. Came to our ER at 2 p.m. with a history of acute chest pain with sweating and vomiting since 12 noon. He was COVID positive, and he was on quarantine for COVID-19 for about a week. He is an ex-smoker. There is no past history of diabetes or hypertension, ischemic heart disease. Actually, he took an ECG from a local hospital and he was advised immediate hospitalization. This was the ECG which was taken in a nearby hospital, which showed ST elevation in the 2-3 AVF as well as some degree of AV dissociation, like we can see the P waves are not properly conducted. And came to our ER as a pillion rider in a bike along with his friend, just collapsed in front of our ER. BP was 70/50 and heart rate was 48 with a complete heart block. ECG showed acute inferior wall MI. There was no RV infarction. Echo was 40% and moderate MR was there. And the ABG showed metabolic acidosis. This is the ECG which was taken in our ER. We can see some ST uptake here, and there are a lot of reciprocal changes here. We can also see some of the conduction disturbances here. And we started on dopamine, noradrenaline, and soda bicarb infusion by anesthetist, and loading dose were given with ticagrelor, ricospirin, and atorvastatin. And the relatives were little delayed, and we waited for 10-15 minutes, and then we spoke through the phone, explained to the relatives, and shifted to the cath lab. The TPI was done. The angiogram was showed occluded proximal RCA. It was a dominant RCA, anomalous origin from the posterior sinus. Normal LAD and LCX and PTCA was, so I'll just show all the procedures in the following slides. PTCA was done with 3x33 Zions expedition, and patient got the rhythm came to sinus, and persistent hypotension was there. BP was 80 systolic in spite of 2 inotropes. IABP was inserted. ACT was 263 in spite of using 15,000 units of heparin during and given 2,500 units of heparin after that, and repeat ACT was 326 when he was shifted to CCU by 4 p.m. So this is the angiogram of the left system. We can see there is no obvious lesions in the left system, and this is the right system. There is an anomalous origin of the RCA, and so it was a little difficult to in this type of primary situation, although we took an AL1, and it was a cakewalk for the wire, and it was slowly easily going. There was no resistance at all because of his young age and high thrombotic burden. You can see once the wire enters, there was a flow established in that RCA, and you can see a tight lesion there, and in the proximal to mid segment, and you can see then I thought it would have been a very easy procedure to go, and it was dilated with a 2 into 10 millimeter balloon, and you can see the flow got established. We can see some lesion here in the proximal RCA. I just wanted to cover this area, although this area is little bit ectatic, and this was a 3 into 33 millimeter Zions expedition. After that, I just did a post dilatation because of the ectatic segment here. I don't want to have a mismatch here, so this was done, and this is the I'll just show the final picture. This is the final result we obtained. There is a TIMI3 flow, and there was no dissection, and there is no flap anywhere. So this with that patient was shifted, and I'll just show. 1 second, I'm sorry. This was the ECG after shifting to CCU. This is the post PTCA ECG immediately after. You can see there is an intermittent pacing coming in, although there was a sinus rhythm here, and you can see the ST segment has settled very well. And still the BP was 80 with the 2 inotropes. I just wanted to put an IABP also in that patient, and we maintained the anticoagulation with the heparin infusion. So continued dopa and noradrenaline. BP was around 100 mm. Eptifibatide infusion was started, and heparin 5,000 units 6th hourly. IABP was flushed continuously with heparin saline, heparin saline. But by 7 p.m. I got a call when I was in home. I got a call from my resident. He called me that a patient has severe chest pain and ST elevation in the inferior leads again. So I thought should be again an inferior segment, so should be a stent thrombosis. Although we did a procedure very well without any a slow flow or anything, even though there is no lack of approximation of the stents and all. So I thought it should be a stent thrombosis anyway. So because the IABP circuit got blocked in spite of heparin saline infusion, we could not record any pressure through that. And BP dropped to 70 systolic when the physician announced me. And then immediately I rushed to the CCU, and I asked the patient to be shifted to cath lab immediately before I come. So when the patient was shifted to cath lab, his BP dropped to only 30 or 40. When I just punctured the femoral artery, then it was only 30 or 40. And you can see the repeat ECG in the CCU when the patient again got the chest pain, again ST elevation in the inferior leads. So this was the IABP which was in. So you can see here again the stent got thrombosed. So you can see very well, and there is a lack of flow. And with so again the wire was immediately inserted, and we just serially dilated with the balloon. So with the 2 millimeter, 3 millimeter everywhere, and immediately the flow was established in this patient. Once the flow was established, immediately the BP came up. Now it is around 80 now. So again, I thought after you can see after dilating with the balloon, there are a lot of thrombus particles inside the stent. So I thought, I don't know what is the reason going in. Even though I got a good result, you can see a lot of thrombus particles here and there. So I don't want to leave these thrombus particles and be a thrombogenic area here. Even though I don't know what is the reason behind the stent thrombosis. It is because of a COVID, high thrombogenicity, or was there any edge dissection which was missed out, or any other thing. So I don't know about that. So I wanted to cover entire thing from the top to bottom with another big stent. So it was around 40 millimeter, I believe, 42, I believe. It's also a Zions Expedition, and I just wanted to cover proximal and mid. So proximal and distal of the previous stent. So this is the again this is a 3.5 millimeter, and again post dilated with the 3.5 millimeter balloon. So this is the final. You can see this is the final result achieved, and I just wanted to check the left system also, whether there is any thrombus inside the left system. Once it was in, the stent was deployed, and the BP again got up, and then it was around 110. So we just slowly weaned off from all the inotropes over the next 2 days, and the patient was put on continuous heparin, as well as ticagrelor was changed to prasugrel in this situation. And during discharge, I just started him on rivaroxaban again. So rivaroxaban, I just started with 5 milligram. So of OD along with the prasugrel and ecosprin, even though there is no guidelines prasugrel, whether the prasugrel can be combined with rivaroxaban or not. But having seen such a thrombogenic patient, like 15,000 units of heparin was used, still the patient had a thrombus. And even in spite of flushing the IABP IABP tube with heparin saline, still it got occluded. A lot of the ACT was little low even after using the 15,000 unit of heparin. So I just wanted to not to take any chance. I just wanted to put him on all the anticoagulants for the first 1 month, and I removed one antiplatelet after 1 month, and he's doing good. So one more short case I'll just present, and the next case will be the same patient, younger patient, little bit older compared to him, 48-year-old male. He's working in IIT, and then he came. Actually, he's also COVID positive, and he had a breathlessness. So IIT doctors thought it should be a COVID, and he was waiting for the COVID test to be done for 2 days, 48 hours. So he was having breathlessness, which increased in severity, and finally they shifted for COVID testing to our hospital. Incidentally, we did ECG which showed ST elevation. COVID was positive. CT score was very high. So he was immediately shifted to COVID ICU. We didn't thrombolize him as it was more than 48 hours. So QS has formed in the inferior leads. And then still the patient BP was little low in that time. So we waited for 24 hours because the BP was little low. He was again taken up for coronary angiogram. So this is the previous patient. He was discharged with this thing. This is the follow-up ECG of the first patient. He was doing now fine. This is the second patient. You can see a large, this is also inferior all MI. You can see a large chunk of thrombus inside the RCA. It was a huge RCA, little bit ectatic also. And I'm just cut shorting all the procedures and just show what is happening here. After putting a wire here, I thought I will not succeed in this case because of the huge thrombus burden. Lots and lots of thrombosection, runs and runs of thrombosection was done 10-15 times I did, and after that I could achieve this thing. And you can see a tight lesion here, and also a huge thrombus protruding here, and the catheter was touching this thing. It was so dangerous. He can migrate out, or it can migrate inside the catheter. So So this is the thing. I just did a PTCA in this mid segment and then post dilated. You can see the huge thrombus still there. I did a multiple manipulation for this proximal thrombus, and I just again I did a thrombosection. Even I crushed with the balloon here. Even I crushed with the balloon, but it was not yielding at all. You can see a pedunculated thrombus now. So finally, I was not, even though I just deeply inserted and just wanted to suck it, but still it was not successful. So I just wanted to crush the thrombus with another stent. It was a stent taken was 4 millimeter, and I just post dilated with the 4.5 millimeter. So you can see this is the final result we could achieve here. So finally, the patient was discharged after 2 days with again the two antiplatelets and one anticoagulant, and finally he was discharged. It's almost 2 months of follow-up. After 2 months, he had an episode of syncope, and his pulse rate was around 40, but it was not a bradycardia, it was a bigeminy, because the bigeminy was not recorded in the recorder, so they thought it was a 40 pulse rate. So immediately I just referred him for EP study and EP specialist, and then EP specialist told it there was no need for any EP study as of now, and he was put on some beta blockers. So after putting a beta blockers, that VPC have gone, and now the ejection fraction has very good improvement was there, and it is now 50%. The RCA territory is slowly picking up. So you can see, just to show 2 or 3 slides about the lot of case reports, a case series of stent thrombosis during COVID-19 pandemic. You can see COVID-19 triggers a hypercoagulable state with high incidence of thrombotic complications. And there are a lot of things, because what is the background? What is the cause for this high thrombogenicity is because of the excessive cytokine storm, so which makes it more prothrombotic. So the endothelial injuries and prothrombotic milieu will be there. So this causes lot of thrombus in COVID-19. So the COVID-19 patients, so lot of higher use of glycoprotein 3B, 2B3A, and thrombus aspiration is done in these type of COVID patients, and higher doses of heparin were required. As in those 2 patients also, they required these type of medications. So these are all the lot of literatures have come. This is the endothelial injury and pro-inflammatory cytokines are the reason behind the trigger of activation of coagulation cascade leading to thromboembolic events in COVID patients. So with that, I'll conclude my talk, and over to Dr. Prabhakar sir for the discussions. Thank you very much, sir.
Thanks, Sundar. That was a very interesting case. Very nice presentation of 2 highly thrombogenic. Basically, what happens in COVID is there is a bidirectional crosstalk between the inflammation and the thrombosis. That's what they say. They use the term bidirectional crosstalk. And you have to bear in mind that the thrombogenicity is not only restricted to patients with myocardial infarction. Even your patients who are on warfarin for a valve, prosthetic valve, you have to monitor your INR periodically, much more frequently than common if you are in a COVID, because they are more prone for thrombosis of the valves also. That is also known. So this increased thrombogenicity is there. But interesting that you had the second case of so much of thrombus despite trying to pull out with the guide catheter, trying to suction off everything. And ultimately, I think you just have to jail the thrombus. I don't think there's nothing much to do. And I think that's finally worked. And your new regimen, unheard of regimen of prasugrel with anticoagulation, 5 milligram. I don't know what 5 milligram, because I don't know whether 5 milligram will work. My justification for 2.5 twice a day, at least there was something about Compass saying so. But 5 milligram, I don't know whether it will act for 24 hours. But anyhow, patients are fine. But do you take a consent for doing all these things and say that I'm giving you something which might produce a bleed? Do you take it in writing to those patients?
Yes, sir. We have a protocol, a consent form here, and because of the use of excessive anticoagulation, the patient may land up with complication. In the last two lines will be like that, sir, in our consent form in the latest COVID PCI forms.
No, not the
So
PCI, the post 5 milligram of rivaroxaban, which is off
I
label.
didn't, I didn't take for these two patients, sir. I didn't take.
But ultimately, I think both the thrombus were well managed. I think protocol wise, you have just gone in and done. And what was the ACT in the first case when you took him to the cath lab for the second time?
Yes, sir. Thank you.
ACT, what was it? What was
Yes,
the ACT?
ACT, first procedure before the complication happened, the ACT was 263. And then we gave 263.
It came to 300. But second time, when he had the thrombus again,
Yes.
the RCA reoccluded totally, and you had to put in a second. At that time, when you started the procedure, what was the ACT?
Because we were continuing on
Correct.
heparin infusion, we didn't say the EACT, sir. We just monitored APTT. So APTT was 70 initially to start with, and it became 32. Again, we increased the heparin dose to 1000 milligram. So before starting the procedure, I didn't see the ACT, but at the end of the procedure, I saw the ACT. It was around 280 or 300, in around 300. So second procedure, after second procedure.
Dr. Srinath?
Yeah, one small observation, sir. Whether this you stented the patient, the first case of RCA stenting. So whether the stent size probably was it an undersized stent to start with? So that was the reason for thrombogenicity, or only it was the COVID which was the reason for the prothrombogenicity. So just
Yes,
a
sir.
hindsight.
Actually, a lot of reason may be behind, because I am just not. Yeah, sir.
It was an acute emergency situation. I agree. Patient was crashing, but
Exactly.
oversizing a stent in such situations, will it really help? So whether a 3.5 to start with
Actually,
itself. Please go ahead, Dr. Sundar.
yes, sir. You are right. Actually, I don't know the reason of stent thrombosis, because in this era of ticagrelor and prasugrel, and I'm not. I am yet to see a lot of stent thrombosis unless it is grossly undersized or something. But still, I have in mind that there is some ectatic portion, might be a undersized stent like 3 millimeter in the first instance, and that's why I wanted to upsize the stent. And although there are a lot of thrombus inside the previous stent, I don't want to leave it there, and I don't want it to be a nidus to again for a thrombus formation. So I just took a 3.5 millimeter, and just I wanted to cover the entire area, and I don't want to leave doubt of edge dissection also. So I wanted to cover from top to bottom. So this was my plan in that situation.
What was the size of the aspiration catheter which was used? 6 French or?
6.
6. Okay. You went radial, right? This was a transradial or a femoral approach? This one femoral only.
Oh, you mean first or second, sir?
First one.
First one.
Yes, first one.
Yeah, first one was, I think it is a femoral approach only. Sir.
Femoral approach, okay. Femoral. Do you have a 7 French aspiration catheter in your stock, or have you used 7 French aspiration catheter? Will it really help in such situations? Because a lot of thrombus load. Second case also.
Yeah, maybe, sir. But I didn't have that. Only 6 French.
A guideliner and try to aspirate through that.
Yeah, guideliner is another option.
Exactly, sir.
Yes,
Exactly. The second case, we should have used a mother and child or a guideliner, which would have been very good.
The dancing thrombus was really interesting.
Great case, Sundar. Great case.
Within a stent, whatever is there, you can probably push the guiding also if it had been ostial. But I think it was nice case and good learning points on the whole thing. I think the next case, Dr. Srinivasan has come in. I think we should call him. Yes, Manohar.
Yeah. Sundar, it's very good managed. In COVID situation, in your first case,
thank you, sir.
It's most polycystic thrombosis because your stent is also thrombosed, and as well as your IABP is also thrombosed. And meantime, you are used to FT-biotide and heparin. Instead of heparin QID, you may start with heparin infusion. Heparin infusion is favorable for in COVID patients.
Exactly, sir. Very, very well point, sir. Very well done. It's a valid, very valid point, sir.
Okay.
Manohar, you can introduce
Good.
Dr. Srinivasan and start the next case, please. Next case, an
Okay.
interesting case of left main stenting from.
Dr. A. Srinivasan is K.N. Srinivasan is a renowned cardiologist in Apollo Hospital. He is a very good interventional cardiologist. Mr. Srinivasan, can you present the case? Mr. Srinivasan?
Srini, you can start sharing.
Please unmute, sir.
Srini, unmute yourself.
Okay, sir. Am I audible?
Yeah, you're good. Your slides are
Okay.
seen, you can start.
Okay, fine. So this is an interesting case of left main stenting, protected left main. This is a 71 years old gentleman, a known diabetic, had a bypass surgery in 2010, about 10 years ago. Presented to us with an angina and exhaustion of class 2 with ejection fraction 50%, PCC of left bundle brain block. Angiographically, we had a native triple vessel with the grafts Lima to LAD and venous graft to PDA were atretic, and the venous graft to OM1 was blocked. So literally he was surviving with venous graft to last OM. And this is the angiography in epicranial and iliocranial view. I want everyone's opinion regarding how we do this. And this is epicaudal and RA caudal. What's your opinion? How many of you think that rota is necessary in this patient? Sir?
Srini, one thing is your guide catheter is exactly on the place where I want to see. It doesn't look very calcified in this. There is calcification more on the LAD side.
Yeah, correct. So even I thought like that. I thought the LAD is more calcific, and the place where the calcium is there is no tight lesion. The lesion is just after the calcium, and so I thought it may be an adventitial calcium.
You
So
have
I
an
started with regular wiring, run through wire. So wired the LAD into 014 run through wire and pre-dilated with 212, then 2.512 and 312 NC balloon. So that's what you are seeing. Afterwards, I did an IVUS. So how many of you use IVUS for left main, the protected left main?
100% for left main.
Selected cases.
No, it's left main. It is 100% for us.
Okay. So I did a left main, an IVUS for this patient, and you can see the IVUS run. From LAD to left main, in the proximal LAD. Eccentric calcification from 12 to 3, extending in the distal left main also. The shaft is okay. You can see that there is some calcium gain. Huge left main. Again, just the ostium, you would have seen a plot there. So this is the frames which I have taken to show it in a better way. So the minimal lumen area in the left main was 4.97, and it was in the LAD it is 3.72. The LAD ostium is also diseased, and the left main ostium is also diseased. Even though the left main ostium is diseased by left main and by angiography, if you see in the iliocranial, but the area we got was 9.7. So how many of you will cover when you consider stenting of the left main to LAD ostium, left main ostium? Do you think we can leave the left main ostium because the MLA is good, or you would like to cover the left main ostium also when you stent from left main to LAD?
So this patient probably will have to cover from the left main ostium.
Even I thought like that only. So I again pre-dilated with a bigger balloon, and just see these 3 waves. Very interesting thing is happening. Just see. Which you have not seen in the first APC.
You open the circumflex.
No, I'll tell you. So what I did was I did the LAD stenting 3 into 28 millimeter DES from mid to proximal just before origin, and after origin, and from the overlapping the LAD stent, then left main to from LAD to left main ostium. So covered completely with 4 into 32 DES. You can see this is the first stent which is positioned first frame, and second stent is positioned second frame, and then pull the balloon out and lab up this stent. Post dilated with 4 into 10 mm LC balloon. And again did the IVUS. You can see the post stenting IVUS stent. Something interesting is happening. Just watch it. The stent is well approximated and uniformly disposed to the vessel. So origin also covered. So to the origin. So this is the frames which I have taken. The distal left main we got about 10.63, and the MLA in LAD was 7.6. So almost 100% increase in the LA, and the LAD ostium 9.87. So it was well approximated, and we got a very good MLA after the post dilatation. And again we went ahead and we flare up the left main ostium. This is the case afterwards. So good blue in the LED. The interesting thing which I said was, if you see the first frame of epicranial angiographically, the distal LED, there was no muscle bridge seen. But after I did the pre-dilatation, you can see that angiographically there is almost significant muscle bridge. It is like 90% stenosis, like that severe muscle bridge is seen in the distal LED. And if you see simultaneously the IVUS run also, you can see that muscle bridge is seen. So simultaneous angio and IVUS run I put on side by side so that you can appreciate the muscle bridge in the angiography post dilated epicranial wave, this one, and the pre-stenting IVUS run. So this is called off-moon sign. In the IVUS, the muscle bridge, you can see that the radiolucent area, which you see the black area, that is the portion of muscle bridge, but the vessel is compressed there. So you are seeing an off-moon sign. This is a reference, it's from the book. So what they say is, the pericardium will be hyperlucent and the muscle will be hypolucent. So the take-home messages where the proximal tight stenosis, as in this patient, hides the distal muscle bridge. So intracardiac imaging helps to delineate the extent of the lesion, the landing zones, the size of the vessel, choosing the right size of the stent, importantly avoiding landing in the muscle bridge, and also the ostial left main lesion. Thank you.
Dr.
About
Nayak?
This is a good presentation, Dr. K. Srinivasan. It's a good demonstration of IVUS.
yes,
You,
Sharing, Srini.
yeah, the muscle bridging you are explained, and the imaging is very good. And this is the advantage of imaging and choosing the size of the stent in left main.
yes, sir.
And L6 is a non-dominant, so there is only provisional stenting is did. But the imaging showed it's excellent. It's the stent opposition is very well, and there is no malopposition, no dissection. Good. Over to Dr. Prabha.
It's a very simple demonstration of how useful the imaging is, and how clearly you can see and do whatever you want. Your positioning, your where you can park your stent, and I think it's imaging. If cost is not an issue, I think it will become part of any procedure, any intervention. And in fact, I saw one case by Mama's Mamas. I don't know whether I told you that, and he did the case and he showed everything looks good. He did an imaging and showed distally there was a significant dissection. I asked him, why did you do the imaging? He had said only one thing, I do imaging for all the cases. And it does come up with surprises like this. And he had to put another stent there distally. Significant, about 60% of dissection was there. But it was not seen on the angiogram at all. So sometimes it does happen. Here you didn't have, you had a zone where you didn't want to park the stent. And I think you had your own advantage of doing an imaging in this. Interesting, good
Yes,
case.
yes.
Thanks, Srini. I think you should stop sharing your this thing.
Yes, sir.
Good reference for calling a half moon sign also.
Yes, sir. Thank you.
Any other comments from others? I think if there are no further comments, I think Srinath, you should introduce and start the last case. Publication stenting in acute MI, Dr. Rahul.
Yes, sir. We'll start. Dr. Rahul is a consultant and interventional cardiologist at JP Heart Institute in Pollachi. Over to you, Dr. Rahul. You can proceed with your case.
Sir, thank you for the introduction, sir. Just a second, sir. I'll just stop. Sorry for the delay, sir. So, hope my slides are visible, sir.
Yeah, you're good.
Yes,
Yeah,
yes.
sir, I'll be presenting a case of bifurcation PCA in STEMI. This is a 54-year-old male who is a known hypertensive smoker presented with antral STEMI. He was taken up for primary PCI. This was the angio which showed LAD totally occluded and mild disease in ramus, and LCX is fairly free of disease, and it was a small caliber vessel. LAD cranial view showing nothing from the LAD territory, and interestingly RCA showed LD was filling almost up to the first diagonal. So what I felt is the lesion is extending up to the ostial LAD. So I thought after doing all the pre-dilatation, I'll think of whether it come into the left main or land just stuck inside the left main. I thought I'll decide after opening up the lesion. And if I am planning for a left main stenting, and this is a trifurcation vessel involving the left LAD, ramus, and LCX. LCX is a small caliber vessel. And LAD had a good collateral, so it can be an acute or chronic lesion. So getting into the LAD will also be a little challenging. That's what I felt because of the nice collaterals from RCA. Routine wire couldn't go through. Had to take field FC after going into the LAD. The ostial LAD lesion was not yielding at all. Multiple balloons were tried, 2.5. 3 NC was also tried, but the lesion didn't give away. So I took a 3 into 10 mm scoring balloon, after which the lesion yielded, but this dilatation immediately when the lesion yielded, I had a dissection in the distal left main. So now the plan was very clear. I had to cover the stent from LM to LAD. So decided to go ahead with left main to LAD stenting, and I decided to treat it as a bifurcation lesion, ignoring the LCX because it is totally free of disease and it was very small caliber. So I converted the trifurcation into a bifurcation and decided to go ahead with a bifurcation strategy. And I plan to go with a single stent strategy. If needed, I thought I'll plan a bailout stenting. LM to LAD stenting was done using a 3 into 48 mm Zines expedition disc, and post dilatation was done, and proximal optimization was also done. After finishing the part, patient developed angina again. His BP dropped to 80, and inotropes were started, and ECG showed new ST elevation. And then I saw the ramus. There is only TIMI2 flow, and patient had a severe angina. So ramus showed a TIMI2 flow. So I wired the ramus using the third new wire. I didn't want to lose any wires, so I didn't want to lose access of any vessel. So I took a new wire, re-entered the ramus through LM to LAD stent, and struts were opened using a 1.58 balloon, and serially it was dilated. So I decided to go ahead, stent the ramus since it was a decent sized vessel. Decided to do a reverse tap. Took a 2.75 28 mm disc, protruded some 1 mm into the left main, and I kept a balloon, 3.5 into 8 balloon in the LAD, and stented the ramus using a 2.75 into 28 mm Zines expedition disc. Then I pulled back the same stent balloon and did a post dilatation also, and finished the kissing balloon inflation with the same balloon because patient was having some angina. I wanted to finish the procedure as quick as possible. So this is the final result. The patient had a TIMI3 flow in both ramus and the LAD. And this was completed with the part in the LM using a 4 into 8 mm NC balloon. So the literature review has showed there is around 11 to 23% of bifurcation lesions which we can see in acute MI. The predominantly involved vessels are LAD and diagonal, and the procedural success rate is similar, but more amount of contrast is needed, and more fluoro time is also noted. So bifurcation stenting in acute MI can be done safely. Reverse bifurcation stenting is can be done if side branch intervention is needed. So if always feasible, go ahead with provisional stenting. If side branch intervention is needed, if it's an Y angulation, we can go for full-out T angulation tap. If side branch intervention is not needed, then we can go ahead with the single stent strategy. If you are planning for upfront two stent strategy, I think DK crush or nano crush can be followed. Thank you. So we can discuss, I think, sir, if anything.
Okay, I think kept it simple, came out simple, came out good.
Thank you, sir.
I think you just stuck to what you wanted to. Left main dissection and you had to stent it. You changed the strategy, went ahead and provisional stenting, and you luckily the angina developed then and there immediately, and in the lab you were able to put another stent into that. And,
Yeah, just now we finished the part. We thought, okay, everything is over, fine. We handled the first dissection happily. Then the patient started with pain. We thought, okay, we start once again from first.
what was the jailed wire in the ramus originally?
The jailed wire was Renato, sir. A new Renato wire was jailed.
We were just discussing the first case and we were thinking, well, whether it's going to be a BMW. That was my curiosity.
In my lab, only there are like 3-4 wires, sir. Only one field FC, run through, Renato, and if needed, Grand Slam. Only 4 wires.
Sometimes it's nice to have fewer choices.
Yes, correct, sir.
Right, good. Any other comments from Srinath? Manohar obviously is gone for a cup of coffee or a drink. I don't know. What about Sundar, Srinath?
Case, sir. Very good case. Good case. Nicely managed.
I kept it simple. I think that was
it kept it simple. Yeah.
I just forgot to recollect. How was the ramus? Was it deceased during?
It was. It had an osteogenesis.
It was deceased, sir. It was deceased.
Okay. That's correct. So the
same balloon being used for pot without an NC. No. I think probably.
Actually, I finished the kissing balloon inflation because I didn't want to take delay. There was like a lot of time happening, and patient there was contrast was also higher, and again a lot of materials were also used. So I pulled back that stent balloon and did the post dilatation of the ramus, and kissing balloon inflation was also done. For pot, I took a new 4x8 mm NC balloon because the stent was protruding out of the ostium, so I didn't want to injure the stent. So I took a new 4x8 NC balloon and finished the repot also.
I think all of us have to probably reconsider our 4 to 4.5s for left main alone, because our left main seem to be pretty big, like what Ken has showed in his case also. I think we probably have to upscale the left main sizing. So whenever we start doing, probably a thought process, I think might come into the picture as we image more, we keep seeing more and more bigger vessels, and I think it's just a mindset. I think that has to come in.
Mostly the LAD sizing is only 3.5, sir. So that is where we err most of the time. So
if you do a 3.5,
we take a 3.5. Yeah, 3.5 go up to 4.55. So choose a stent like that.
Yes, sir. Right. I think we should not take too much of time. Any other last comments from anybody?
Right.
I think if everything is good, say thanks to all our participants for a very good interactive discussion. Thank you very much to all of you for being with us today. We have one more session tomorrow. I will send you the links and another set of investigations. Dr. Rajendran couldn't present today. I think he'll come in tomorrow. I'll send you the link. I welcome you all for tomorrow's meeting also, and thank you so much, and thanks to the all the panelists and all the members and everybody for being part of the Merit Trust meeting today. And Thank you so much. Have a nice evening and good night to all of you. Thank you so much.
Thank you, sir. Good
Thank
night,
you so
sir.
much, sir.
Good night.
Good night, sir.
Night.
Good night.
Recording has stopped. The meeting has ended.